what's fascinating is we're breaking down more and more the biology of how pancreatic cancer works. We're going to see later on when we talk about new and emerging therapies, it gives us more targets that we just don't think again about the cell itself, but we think about what's around it. You know, we're also looking towards precision medicine, right? That was the ASCO theme. We're seeing more of this in ESMO now about how do we, from the limited things that we know, translate and try to find biomarkers or components, molecular components of the pancreas cancer where we could potentially individualize treatment for patients. Winson, tell us a little bit about how you approach when you first see a patient with advanced pancreas cancer. Do you order molecular profiling? What do you think about the biopsy? Tell us your approach in Canada.
Sure. So, I mean, I just want to start off by just echoing kind of what I'm hearing. I think things have really advanced a lot in the last 8 years I've been in practice. And as you alluded to, you know, I think we're learning more about the biology and the potential utility of biomarkers in terms of individualizing therapy. So, to that point, I think all of us are well aware that in a fraction of pancreatic cancer patients, they express certain mutations. So, BRCA mutation is one example. In Canada, it's not universal, but we are starting to test it more routinely in certain demographics. So a young female, for example, with a family history of other cancers, we would routinely test them. And as you mentioned already, I think it also has implications in terms of therapeutic decision-making as well down the road.
Yeah, and we'll be talking a little bit more about some of the specific drugs that we might think about for patients with BRCA mutations. You know, there's this code word, especially among GI oncology, about microsatellite instability. Do we see microsatellite instability in pancreas cancer, Dr. Saab?
We do, although rarely. So it's probably about 0.5%. But I think now that we have, and we do understand that these PD-1 inhibitors have tremendous activity in MSI high tumors, regardless of the origin, I think it's almost a mandate for us, where feasible, to test every adenocarcinoma for MSI, and we're doing that. You know, from personal experience, I've had at least a couple of patients where MSI high was found in their adenocarcinoma. One actually in the setting of Lynch, and that patient failed a couple of lines of chemotherapy, was placed on back then a clinical trial with pembrolizumab and had a CR.
Yeah.
Something that you rarely see in pancreas cancer, and continues to have a CR 2.5 years after. So pretty significant response, and you have to see that to be convinced about the value, even at a rate of 0.5%, to do that more universally.
And Manuel, you were one of the pioneers at looking at tumor tissue samples and biopsies and noting the importance of having an adequate biopsy for patients. You know, pancreas cancer, oftentimes I'll see patients come to me who've had fine needle aspirations for diagnosis. Can you tell us a little bit more about what your recommendations would be in this modern era of tissue acquisition and what you look for?
Yep. That's very true. Patients continue to be mainly diagnosed by fine needle aspirates, mainly through endoscopy. The reality is that now you can do fine needle biopsies very safely through endoscopy as well, and that, at least in our institution, is now the preferred method for two reasons. One, because you of course acquire more tissue that then allows you to do a more detailed pathological evaluation, but also the opportunity to do genomics that otherwise in fine needle aspirates are very hard to do. Even in the fine needle biopsies, we sometimes get very little tissue, and the genomics come back like clean or negative. We use it also to develop living models, like organoids and PDX, and you can grow them very nicely from the biopsies, not so much from the aspirates. So I think that if we want to really make progress, we will need to do more biopsies and less FNAs.
Yeah, that's a big real world initiative, is that education of don't do FNAs unless you absolutely have to. The core needle biopsy is the thing to do. It's back to the old tissue is the issue. Now, Thomas, you've been doing some work looking at liquid biopsies. Tell us a little bit about that.
Yeah, well, this comes back to what Manuel is saying, that sometimes we actually fail in taking biopsies, even FNAs. And this is, we are running a neoadjuvant trial in Germany. This is up to 30%, even in experienced centers. Even using the new needles, which are more flexible, you can bend them, but you still can get a tissue core. And so there is, of course, a need or a desire for having alternative means that are simpler and precise. Particularly when you want neoadjuvant treatment, you can't do that without actually any diagnosis. You can operate on patients, but you cannot really give chemotherapy. And we've done some studies on liquid biopsies, and there were some posters also at ASCO and also in this program here. But one has to say, in the critical tumors, the smaller tumors, where it's very hard to get tissue, are also those that in even 50% of cases fail to give you a signal with circulating tumor DNA. In particular, also if you are very sensitive, so if you do digital droplet PCR, not NGS sequencing, so you're using the most sensitive method, in 50% you do not get a signal. So we are not really there yet. Maybe refining these methods, looking, for example, for tumor-secreted exosomes instead of ctDNA, maybe we're getting a little bit better, but there is still some research to do. So the message is there probably will be more coming. In particular, in combination with other markers that may, not as a standalone, but in combination, let's say we see a 99 plus novel markers that have just been reported, like this thrombospondin 2. This could be a very interesting way of differentiating, diagnosing and differentiating tumors also from chronic pancreatitis, which is sometimes also not easy to do.
So interesting, because I think right now we're trying to move more towards the liquid biopsy, the liquid evaluation of the tumor, and how does this apply to treatment options. Winson, we all know that the best way to treat pancreas cancer is to take it out. And that means early detection. And that's such a key piece. And Thomas just alluded to some data that we've recently seen looking at some markers in the blood that might help us detect pancreas cancers earlier.
Right, it's quite exciting work. I think we're all familiar in using C19-9 when we monitor a patient. And as you're all aware or familiar with, is not a very perfect marker. So the question now is, how do we advance things further and perhaps perfect that kind of methodology? So there was a couple abstracts in the last year to look at thrombospondin and other biomarkers. And I would say that they're still kind of early days yet. It's not ready for prime time, but I think the results are very promising in terms of how can we best fine-tune things.
Absolutely. And so, with this section, we've talked a lot about the future and a lot about the science that's emerging and ways that we're going to translate that science into potential treatment options. I guess the takeaway for our audience is knowing that the future is bright, there's a lot that's coming, but just to make sure with your patients, the importance of getting that proper biopsy, to try to get the core if possible, to consider whether or not in certain patient populations you might want to do profiling, you might want to check MSI, you might want to look into BRCA. So for the take home, for people, does everybody agree that that's, for the practicing oncologist, there's a lot to come, but make sure we get adequate tissue?
And also, I think, obviously, the patient who presents with metastatic disease, you would biopsy the liver. You can get high-quality core tissue from there.
But it might be also, just to mention that, it might be worthwhile, if you fail at your center, it might be really worthwhile to refer the patient to an endoscopy center of excellence. Why? Because otherwise you drag on and people having 3-4 biopsies taken and there's still no diagnosis, and then if a patient has pancreatic cancer, it just delays all the sensible novel next approaches, and therefore it might be sensible if you fail at your center, maybe you try another one for this diagnosis.